Hello, my name is Will Prosser. I am presenting on hypertonic saline and traumatic brain injury for the UFCCP class, spring 2026. Um, the use of hypertonic saline in the management of traumatic brain injury is an important and ever evolving topic in critical care medicine. In this presentation, I will begin by reviewing the pathophysiology of traumatic brain injury and the development of increased intracranial pressure. Next, I will discuss the pharmacodynamics of hypertonic saline and its role in neurocritical care. I will then examine the current evidence surrounding the clinical applications of hypertonic saline. Finally, I'll compare the evidence supporting the use of hypertonic saline in both the pre-hospital and in-hospital management of patients with traumatic brain injury. Traumatic brain injury occurs when an external force is significant enough to cause structural or functional damage to the brain. Traumatic brain injury can present in many forms, ranging from mild concussion to severe intracranial injury. One major complication associated with traumatic brain injury is intracranial hemorrhage, which can lead to rapidly increasing ICP. The development of increased ICP can be explained by the Monro-Kelly doctrine. The doctrine states that the skull is a fixed rigid compartment with limited capacity for expansion. Within the cranial vault, intracranial volume is composed of approximately 80% brain tissue, 10% blood, and 10% CSF. An increase in one of these components, such as blood from intracranial hemorrhage, has to be compensated for by a decrease in another component to maintain normal pressure. Once these compensatory mechanisms are exhausted, intracranial pressure rises rapidly, reducing cerebral perfusion and increasing the risk of brain herniation. Brain herniation is when the brain tissue is displaced through structures, typically the foramen magnum. This is a life-threatening neurological emergency. Hypertonic saline is a hyperosmolar solution. This means that it has a higher concentration of solutes than plasma. When we administer hypertonic saline, it causes an increase in serum osmolarity, creating an osmotic gradient between the intravascular space and the surrounding tissues. When hypertonic saline is administered in the setting of traumatic brain injury, this osmotic gradient draws fluid from the edematous brain tissue back into the vasculature. This results in a reduction in cerebral edema and brain tissue volume, which can lead to decreased intracranial pressure and decrease the risk of brain herniation. Hypertonic saline is typically used as adjunctive therapy in neurocritical care for select patients with traumatic brain injury. The first piece of evidence that we have is the evaluation of complications associated with hypertonic saline versus mannitol in the management of intracranial hypertension and their mitigation strategies, a systemic review. Mannitol, as most of you know, is a diuretic more traditionally used in the setting of traumatic brain injury. This study is a systemic review comparing the use of hypertonic saline to mannitol. It included 7 studies consisting of 3 randomized control trials and 4 observational studies with a total of 14,367 patients. The primary findings of this meta-analysis were that, of the systemic review, were that the patients that received hypertonic saline as opposed to mannitol had a reduced risk of acute kidney injury and a reduced risk of hemodynamic instability. This showed even more benefit in at-risk populations such as the elderly and patients that already suffered from renal impairment. Mortality outcomes were generally comparable between the two groups, but it demonstrated that there may be potential clinical benefits of the use of hypertonic saline in the management of traumatic brain injury. Next, we have comparing the effects of mannitol and hypertonic saline in severe traumatic brain injury patients with elevated intracranial pressure. This is another systemic review. It compared efficacy of hypertonic saline and mannitol once again, but this time with 637 patients from 15 different studies. There still was no clinically significant reduction in mortality, but there was clinically significant reduction in the length of ICU stay in these patients. Next, we have out-of-hospital hypertonic saline resuscitation following severe traumatic brain injury. This is a randomized control trial. It evaluated the efficacy of hypertonic saline in the pre-hospital environment. This study included 1,331 patients, all of them greater than 15 years of age. These patients received hypertonic saline prior to arrival at the emergency department. There was no significant clinical benefit observed when compared to resuscitation with normal saline. Next, we have a much smaller study. This is a randomized control trial comparing the effects of 8.4% sodium bicarbonate, which is also a hypertonic solution, and 5% sodium chloride on raised intracranial pressure after traumatic brain injury. This study evaluated 20 episodes of increased intracranial pressure in 11 different patients. It examined the use of sodium bicarbonate compared to more traditional hypertonic saline therapies. There was no significant difference in mortality observed. This, while it could seem benign, could potentially have applications for the world of emergency medical services solely due to the accessibility of sodium bicarbonate. However, when evaluating this and the other evidence present for pre-hospital administration of hypertonic saline, it's very, very limited. Lastly, our up-to-date article just covers the epidemiology, pathophysiology, and classification of traumatic brain injury and dives deeper into the morbidity, mortality, and long-term disability associated with traumatic brain injury. I would like to thank all of you guys for listening, and I really enjoyed making this project and learning. Thank you, guys.